Good morning, everyone. You can hear? No? So, psychotherapy should begin after an evaluation process that includes the parents. Why? Why should this be so? This is not happening often. Because the parents must support the process of psychotherapy. They know their child better than anyone. They must share their view of the problem and its apparent time course. They must provide the developmental history of the pregnancy, the early life of the child, the developmental challenges, including the strengths of the child and the limitations of that young person. And they must tell, because they're the only ones who really know, what the previous medical and psychiatric interventions have been. And they must assess the trustworthiness of the psychotherapist. The elements of an evaluation might include meeting with the minor and the parents together first, meeting alone with the minor then, meeting alone then with the parents, possible psychological testing of the child, and then finally a summary meeting with the minor and the parents together for the treatment planning process. What are we going to do next, and what should we focus on? Recommendations concerning what, as I just said, the psychotherapy should focus on, what the mental health targets for improvement are, and then we need to think about the formats of the therapy process, which can be combined or given in certain sequences. Parental guidance, vital process. Individual therapy of the minor, quite a challenging process. Family therapy in various combinations with the minor, with the mother, with the father, with the minor, and so forth. Medication for the child. A group socialization experiences, or what we commonly call group therapy. So here are the problems in the science of psychotherapy for trans-identified youth as I perceive them. There is no strong objective evidence that psychotherapy can facilitate a return to the cisgender role during its process. There are no placebo-controlled trials available. There is no systematic follow-up of any therapist or any clinic's efforts. The emphasis in that sentence is systematic. There's no agreed-upon method that has been defined for how to help these children. Right. All positive claims are seen as case history, case reports, or very small case series. They're proof of concept. In other words, when someone presents a case history or a series of case histories where a child does much better both mentally and desists, that's just the proof of concept. It can happen. Yet, there's a cultural tradition that points to psychotherapy. The psychological approaches for child and adolescent dilemmas exist for all developmental, behavioral, and subjective issues of youth. This is how we think about, historically, what to do when a child is having difficulty, when a minor is having difficulty. The whole field of child and adolescent psychology and child and adolescent psychiatry have been created to deal with the countless developmental challenges that children face. And then there is the matter of our intuitive beliefs about life. Intuitive means we have knowledge that we don't know where it came from, right? Parents have an intuition that a new identity carries a great risk for all members of the family. Parents have an intuitive sense that affirmative care precludes many of life's possibilities. And they also have an intuitive belief that problems can be outgrown within professional relationships, as we parents have seen, that our early challenges of our children are outgrown in our intimate relationships, our ongoing relationships with our own children. Now, folks, therapists are not all alike. We differ. We endorse different schools of thought. We differ in our educational degrees and our life experiences. We differ in our sex, in our sexual orientation, in our gender identity, in our years of experience, and our concepts, our personal concepts of how is it that I am to be helpful to any person. We work in person, we sometimes work virtually, and sometimes we work both between virtual and in person. And of course, each of us have a unique personality. So I want to picture these two lions. I'm trying to say that these sleepy-looking creatures seem sort of dull, resting. But they're calm, although they're calm appearing, they are to me like the parents, who are alert and quite discriminating and can pounce in an instant when they see an opportunity, a danger or an opportunity to feed. So I think parents need to interview us potential therapists by phone. And we can ask a few questions. Parents can ask a few questions. What experience have you had with this problem? Have you read the CAS report? What is your process of evaluation with a person of my child's age? Do you have availability to work with new patients for an extended period of time? We don't want to meet a therapist, pour our hearts out, and say, well, I'm actually moving to Zimbabwe next week. Right. What frequency of sessions do you prefer? And how do you relate to parents while working with their child? These are reasonable questions to ask and should not be responded to defensively. If so, run. So what parents should know about transgender identifying minors? A new gender identity is a surface manifestation of something hidden that the patient will not readily reveal or may not yet understand. The cause of a new gender identity is never one thing. And psychotherapy is a slow process of helping a person to recognize and struggle with the reasons for the gender reinvention, to struggle to trust the therapist with their private thoughts, their concerns, and how they consider these options. It is a slow process to consider, for the minor to consider the wisdom of the new gender for the long term. As I like to say to the minor, you're the captain of your ship, and we want to be sure you don't steer it right into the rocks. So most of these minors are trying to escape a profound disappointment with themselves, and they have a fear of being greatly deficient, becoming a greatly deficient man or a greatly deficient woman. They have imagined that they will have a happier life in the other gender. That's why they reinvented their gender. They think they will be happier than they have been. Right? Now, some of these young people passionately do not want to be like someone in their family or do not want to ever experience physical, sexual, psychological abuse or abandonment another time. So here is Dr. Levine's fundamental assumption, which you may disagree with. A new transgender identity is a private, often somewhat unconscious, creative, ambivalent, maladaptive, intrapsychic solution to a set of symptomatic problems. I want to emphasize the word maladaptive. There's the disagreement, the cultural disagreement. I take a stand. This is not in their best interest. So a new trans identity is a creative, unconscious, but ambivalent solution to a set of perceived existential problems that they don't want to discuss. Therein lies the task of the psychotherapist. It is not a trans identity. A new trans identity is not a genetically dictated phenomenon, although minors prefer this concept. It bypasses all the unconscious, all the creative, all the maladaptive, all the existential pain. It's essential, it's biologic. And our job is to begin to help the child see it's a bit more complicated. So I want to remind all of us who deal with adolescents, who used to be an adolescent, and who have adolescent children. There are 6 often charming, sometimes exasperating characteristics of teenagers. They're prematurely certain. They're emotionally intense. That is, they're passionate. They often write poetry. They are intensely reactive to their standings with their peers, which is one of the existential pains of their existence. They're porously absorbing youth culture involving music, politics, the internet, and clothing styles. And here is the subtle thing. They are seeking a trustworthy new authority figure, such as a teacher, a therapist, a coach, a politician, or a clergy person, while evidencing on the surface a distrusting cynicism of all those authority figures. And the most important thing, parents, about adolescence, if you can recall yourself and the pathways through which you passed for 10 years, is that adolescents are changeable. Whatever we do with these children, these minors, we need to keep these 6 characteristics in mind. Now, a goal of healthy adolescence is a stable, functional sense of self that has a certain degree of optimism about the future. Developmental tasks that must be gradually accomplished over a decade of this time period include a non-conflicted sexual identity in terms of, notice these words, sexual identity. It has 3 components: gender identity, orientation, and intention. Intention is what a person wants to do with their partner's body and have done to their bodies during sexual excitement. 2, comfort with masturbation, and then finally with partner sexual expression. Easier said than done. 3, a clarification of my vocational possibilities. 4, skill building in terms of interest, personal interests. We don't much care what the interests are. They should develop skills in their interest area, right? Increasing self-awareness, and as that happens, consequently, increasing awareness of the psychology of other people. Increasing ability to self-manage without dependence or substances like alcohol or marijuana. Can you just live your life unto yourself? Right? And a gradual ability to be away from parents without crises. However, adolescents differ from one another. They differ in intelligence, in talents, in comfort, in connection, in comfort with sharing internal processes, in their fundamental mental health, and in their personal, private, past, and known life experiences. So even though teenagers have those 6 characteristics, they're quite different. So every therapist is meeting a new person for the first time that's unique from every other person they've ever talked with. So I need you to appreciate the challenges of psychotherapy. Psychotherapy is an evolving relationship whose aim is to improve the life of the patient. The aim is attained through the therapist's ability to connect, to respect, to facilitate insight, and to remain calm when the patient is not. Right? The therapist must become valuable to the patient. The patient must want to see the therapist after an initial period because the child recognizes this person has something valuable to share with me. This person can help me. The therapist can never know, however, parents, they never can know what is happening with your child fully. No patient should be expected to share most aspects of the self at any given time. The unseen work of therapy takes place not during the therapy session, between the therapy sessions, as the patient processes what we talked about in the last session. There's always something more to discuss, even when the patient declares, I can't think of anything to say today. I don't know what to talk about today. We therapists sometimes think, I wonder what this person doesn't want to talk about today. Let that sink in for a minute. I don't know what to talk about is a defense against wanting to talk about something really important. Now, pessimistically, I want to share with you, science is not likely to greatly improve psychotherapy. The essence of psychotherapy lies in the subjectivities of the patient and the therapist. The essence of science rests upon objectivities. A number is chosen in the range of 1 to 5 for a host of topics that are then added to create a score. Scientific studies objectify topics that can be counted often in a yes or no manner. Suicidal thoughts, having panic attacks, self-harm, are you employed, do you have a sexual partner, do you use drugs, do you have family support, do you like your mother, right? Friends have you had friendships in the past 30 days? That's how science works. There is no science with objective measures. Psychotherapy is not science. It's the interaction of the subjectivities, almost impossible to summarize. So the reality about science and psychotherapy. Now before a clinical experiment, a high-level clinical experiment is begun, behavioral scientists, often in committees, must define an important question. They must decide what to measure, to find valid means of measuring 2 or 3 relevant variables, to create a baseline and a follow-up so they can compare, and to define a control group, even though to measure the effect of those variables without psychotherapy. So we have to have a group that has psychotherapy and a group that doesn't have psychotherapy, right? A therapy method must be defined, even though, as I've just said, it will vary from therapist to therapist, even though we say we're doing this kind of therapy, right? So prospective studies need many subjects, as you've just heard, huge amount of funding, and it takes years to complete. Ladies and gentlemen, science is not going to improve our ability to do psychotherapy. It can study the natural history, which is a vital question. As a result, organizations need to gather psychotherapists together to define common experiences and to listen to one another's struggles, opinions, and suggestions. Thus, topics for meetings such as this range from the patients, things about the patients, things about the parents, things about the therapist and society in general. And we got a serious problem we're facing. So these are almost my final thoughts. For you therapists in the audience, you are a special form of teacher. You are more psychologically aware, sophisticated, erudite than your patient. Even though you may not feel that's true, but you are. You share an idea new to the patient each session, such as summarizing what we talked about in this session, explaining the concept of ambivalence, teaching them what a defense is, showing them that I, the therapist, and you, the patient, each have different internal conflicts. And we teach them what projection is. You see, I'm guilty for keeping a secret from my parents, so I hate them. I'm projecting something inside onto them and thinking that they're hateful people, or you're a transphobic therapist. Right. We do not assume that the patient, please do not assume that the patient understands your language, your words. Casually explain what some words mean. I often ask a person what they think that word I just used meant, and I see they don't. I'm guilty of speaking over them, even though I think my command of English is pretty good, but I forget this is a 16-year-old, and I didn't have that vocabulary when I was 16, and I didn't know what ambivalence was when I was 16 years of age. So we need to understand we're speaking words, a language that is new to them, and they will pretend like they understand, and so it just goes right over their head. So we therapists need to know that. So for parents, you should be able to talk to the therapist. Even serious diagnoses, and I think autism is a serious diagnosis, for example. Perhaps it's not as serious as schizophrenia, but it can be helpful to the parents to get that diagnosis. I need to tell you, so many parents eventually thank me for telling them I think their child is autistic. See? It helps people to be realistic and know what they're facing. So, parents, ask questions, seek advice, read the professional literature. Please, read the professional literature. You are not your child's enemy. You are not transphobic. You're not a trans hater. You are a trans wary, trans concerned, trans worried, normal person, loving person. You love your child, and you're protecting that child, just like that lion and lioness I showed you. So my final slide. For psychotherapy to work, parent, patient, and therapist must have faith in connection, in relationship, in respectful bond that clarifies the existential dilemmas and the future of the child. So if I have a few minutes, I'm going to shut up and listen to you.
We have a question.
Hi, thank you, Stephen. Can you hear me? Yeah. I'm asking, that was gorgeous, really, really gorgeous. I love the humanity in your approach. I'm asking a question from the live stream on behalf of somebody from the live stream who wanted to know, what's your definition of gender identity? An easy one.
My gender identity is my current but evolving concept of how to be a man in this world. So it's my sense of what other people call masculinity, and I recognize that in terms of media advertisement, masculinity is this wide. In terms of reality, masculinity is beyond the span of my arms. There's an endless way to do masculine. And I also recognize within my masculinity there are strong feminine identifications because I had a very wonderful mother. More, Stella? No.
Are we on now? Oh, we're on now. Okay, I think we can all recognize that parents, when faced with this issue in their home, are typically not just wanting help, but a little bit desperate for it. And the first thing a lot of parents do is try to find a therapist. And so my question is, if you have a teen or young adult child who doesn't want to go to therapy, is there any likelihood that a reluctant patient will progress in therapy if it is the parent's desire that the child go to therapy?
Yeah, I think before we sick our unwilling child on a therapist, we ought to think of ourselves as the therapist and talk about why is it that you're so adverse to seeing a therapist? It won't help. The therapist will take away my gender identity. I'm not troubled. I'm actually happy, mother. And I would say that parents' worries about a trans identification of their teenager, especially their reluctant teenager, represent, and this is what I tell people during the evaluation process, even though the child pretends like they have no ambivalent and they have no worries and they think this is a very fine idea and this is their genuine self, I think parents' worries are just the worries that the child is going to have in 6 months, 12 months, or 2 years from now. And so we are a team. You see, the parents are not the enemy. The parent and the child is a team, and we hold concerns. But younger people, like 12-year-olds, cannot conceptualize the sexual impact of estrogen and testosterone and so forth. They don't understand infertility, right? They don't understand human relations, but we do. We parents, we lions do. And so before a child is sent to a therapist who may be unknown to the parents, as I've said, I think we need to be the therapist. We need to have ongoing dialogue, which is very difficult if the person calls you the enemy. And so I would just then label that we are at a profound impasse and that everyone in the family is in trouble now, and we need to continue talking. And it may very well be that the therapist will not be able to help, you see, but the child has to stay in the home and has to be respected for his solution, even though if you take my assumption, you see, you will be able to calmly represent yourself as a worried person and to share the fact that while you're not worried, your dad and I are quite worried about you. And maybe that will change in 2 months or 3 months. If psychotherapy is a slow process, adolescence is a slow process. We got 10 years to work this out, you see. But I recognize we have certain situations we can't solve. We can't solve. I feel like I sit with tragedy every day.
We have time for 2 more questions. We'll take this one and then Christina over there.
Hi. The reality in many states is that psychotherapists can risk their licenses if they acknowledge that there might be something going on other than a trans identity. In addition to that, I've heard from many parents who have been misled by psychotherapists who said, oh, sure, we'll talk about this, we'll talk about that, and immediately affirm.
Yes.
So under those circumstances, is it enough to say, are you familiar with the CAS report? And is it even wise, I hate to say this because I have a lot of friends who are therapists, to consider psychotherapy under those circumstances?
I think we need to encourage all parents to be the lion, to ask these on the telephone or in person, to meet first with the therapist and ask these questions. You have to support the psychotherapy. You don't want to put your child in with somebody who thought that they were taught during their training that the best thing to do is to affirm, and that parents who don't affirm are evil. You would recognize that on the telephone or in the first visit, and that is not the therapist for your family. So I understand this is a big problem. Many parents complain they cannot find a non-affirmative therapist. I mean, you parents know that, right? But I think Genspect is doing something about that. I mean, look at us. Here we are. Please don't make Dr. Levine into the savior who can solve all these problems. Please. Is there another question? Yes. Thank you. Goodbye.